Is it okay?
Good.
Bueno, pues empezamos en esta sesión de Perio MX Academy con el doctor Eirk Salvesen. Bienvenido, Eirk. So, thank you so much again. So, immediacy and decision making in aesthetic zone. Thank you so much.
Hey, thank you. Thank you for inviting me, Carlos. It's been some months since I first met you in my life, and we had a lot of fun during a couple of days together. And I think we are sharing much of the same passion for sharing knowledge and also discussing, globally around with colleagues. And with the whole situation that we're facing at the moment, everybody is now online doing webinars, and we are connecting through every countries and all over the globe. So it's a pleasure to be invited here, and thank you. It's basically my first time in Mexico. So this is good. So I'm looking forward to it. So thank you for spending the next hour or something with me. I will be talking in English, and I know that because I try to follow your normal lectures, but they're all in Spanish, and my Spanish is like on buen dia and muchas gracias. That's where I stop. So this will be in English. So if there's any misunderstandings or trouble with the language afterwards, you will have my contact details, and please feel free to reach out if there's anything. So I will be spending the next hour talking about how I approach the aesthetic zone when we talk on implant dentistry. And I will try to highlight a little bit about the different implant specifics that I need when I work in the aesthetic zone, and also some of the decision making that you need to do with all the small different details that you need to take into account to be sure that you make the correct decision. And I think when we talk about all these things, we forget to basically talk a little bit about the needs of our patients, because the producers and the implant companies and everybody's throwing out, it could be a surface of an implant, it could be a design of an implant, it could be basically a new tool, but it doesn't matter, because it's just small things that they improve and they develop as a part of a business proposal from the different manufacturers. And also they come with different cassettes and everything. And I think this is very much mixed in the communication that you will see. Now, I know that most of the participants in here are graduates that will be very much hit by the commercials coming around, and you always need to look into the systems that they're actually providing solutions. Because all these small details, doesn't matter if there's no total solution within the system, if it doesn't have a connection between the surgical fit and the prosthetic fit and the components, it doesn't matter. So it's solutions all the time. So please, in all that you do, when you move along in your professional career, always look for the total solution, because the patients are not interested in different implant designs. That's something for us. The patients need solutions. So when we look at implant dentistry, I think it's really important that we acknowledge that there is a primary goal, which is clearly defined on how we work on implant therapy. But I also think we need to respect that the secondary goals might be as important for the patients as the primary goals. So while the primary goals will be success, predictability, stability, and low complication rate, the secondary goals are probably more interesting for the patients, because those goals will have us as professionals try to reach treatment procedures, way to treat the patients, how to go through this with the fewest possible numbers of surgeries, with low pain and morbidity, short healing periods, and basically short overall treatment time. So exemplifying this, you'll see this case. This is a young lady being referred to us after losing one of her lateral incisors. You see the healing pattern. If you see on the middle picture, you see the healing pattern, which is classical. You will have the buccal resorption or remodeling, basically. That's what it is, of the bone. And this is how it's going to look. So, but there's probably going to be enough bone to place an implant. So after this, we place an implant. As this is done, you will see on the way that we do the incision is important, because we're not touching the sulcus of the neighboring teeth, due to what you probably learned about remodeling when we do a periosteal flap. So we're closing that one. We're using xenograft and resorbable membrane, not because we basically need bone, but because we need something to counter the soft tissue. So because you see the smile line, so there's a concavity around the implant, it's not going to be natural. And then we close it as a primary closure. We do the abutment surgery 3 months down the road, and we have a stable result in 5 years' time. But it takes about 8 months from tooth to tooth. And that's the whole challenge. I mean, the treatment is successful, the follow-up is good, but it took for this young lady from the tooth was extracted until the permanent final crown was screw retained, it took her 8 months. And 8 months, at least in my part of the world, is not a good thing when you walk around with the removable denture for a young girl. So why are we not looking into the more of challenging these established things and going more for an immediate approach that will give the patient a tooth much more rapidly as it was done with the classical protocols? Another young lady, fairly high smile line, losing what you see is just a deciduous tooth. You see there's a missing lateral incisor, so the canine is moved, as the orthodontist likes to do, they move them into the lateral position, and then you have the deciduous tooth. When you extract a tooth like that, which basically has no root, that's why it's extracted, why don't you place an implant in that specific site? Of course we do. So if you place an implant at the same time of surgery, you see that there's basically no surgery. There's no incisions. We're not touching the papilla of the neighboring teeth. This is something that you can do by experience. We're doing a chair-side temporary restoration, as you also see, and at the bottom picture, you'll see it inserted. This is 60 minutes after we extracted the tooth. There's another tooth in, which is, you know, maintaining and stabilizing the soft tissue. And if you look at the papilla architecture of this specific case, that is a challenge to maintain if we're not placing anything there straight away after surgery. So you'll see the healing now. You'll see when the prosthodontist is inserting the final restoration. And at the bottom, you'll see the 10-year follow-up. And it took about 60 minutes from tooth to tooth. Okay, it's a temporary tooth, but the patient is still having a fixed restoration and is smiling at the same day of surgery. So this is what I like to do, and this is what we started developing in our own practice about 15 years ago. Then we had done, I've been working with implant dentistry for 21 years. And after working classical protocols, doing delayed or conventional insertion and conventional loading or delayed loading, you start to look into the way how to make this better for the patients. Because it's gonna be a competitive world also. So if I can add this to my toolbox, I'm probably going to win the competition amongst the patients because I can offer a predictable solution much more rapidly with fewer visits than my competitors. So are we doing something completely new in implant dentistry? Most of you have probably read through some of the implant history. So you know that from the beginning, or basically middle 60s, when Professor Brånemark was by coincidence discovering the osseointegration, you know that it took about 20 years. There was a conference in Toronto in 1982. This is basically the groundbreaking conference in implant dentistry. This is where it was established that screw-shaped titanium machined surfaces were the choice or the material of choice to use for implants in the oral area. And as we did that from 1982 up to 1990, we were treating not only full arches, but also single teeth. And we did some multiple unit bridges, and everything was developed. So basically by the millennium shift, we could treat all patients. We had short implants. We were discovering zygomas that we could do. We could do bone augmentation because we discovered how to do that. We could do most of the soft tissue things that we're doing today. So from the millennium shift until now, what we are doing is refining implant dentistry. So we're just trying to make things, the small details, a little bit better than what they were yesterday. But we're not reinventing implant dentistry. It's already established. but we're trying to refine the solutions. So by not challenging the primary goals, by still keeping predictability, high degree of success, low complication rate as the golden standard, we should add more. We should add the patient perspective in this of less surgery, shorter healing times, and shorter overall treatment times for the patients. Is this something that we're experimenting or doing like out of the box? No, not at all. Immediate treatment concepts have been looked upon, researched on, documented for more than 2 decades. So by building on the solid foundation of implant dentistry and then adding these new concepts, we're getting a major insight into how to do these treatments, and we've also documented and clinically validated how to do these treatments. And if you look at big ITI groups, like the group that Dean Morton was heading, they were also looking at the evidence and saying that, hey, implant survival is not affected by implant placement or loading protocols, provided that careful patient assessment and planning has been undertaken. Well, it's like every day, it's case selection. We're not showing or shooting implants in, we're doing case selections. The other group that I would like, if anyone of you after this gets more interested in reading on immediacy in implant treatment, I would recommend you to read a lot from Joseph Kahn, which I think is in Loma Linda now in the US, which is one of the groups that has been looking really a lot on immediate placements and immediate restorations. So that will be one of them that I would recommend for you. If we go a little bit theoretically and just look upon how we use these rhetorical names that we're using, immediate placement. Well, immediate placement is placing an implant at the time of extraction. So that's a fair point, that one we can use. Now we have what we call the early placements. And the early placements and the definition of early placement has to do with the clinical situation that you're facing. So after a period of 4 to 8 weeks, you will typically see soft tissue closure, but there will be little bone healing in the area. After 12 to 16 weeks, you will basically have quite a lot of bone healing, but it will be partial and it will still be a little bit of woven bone. So it will be a little bit softer. You need to know that when you enter. And then you have late placement, which is healed bone basically all over in the place. And then we talk about immediate restoration. And that means that we're putting a restoration on top of the implant immediately after surgery. There is no occlusal cuts. And it's got tons of names like provisionalization, temporization, whatever. But to me, it's getting the patient out of the, out of the clinic, out of the surgery, with the tooth on top of the implant at the day of surgery. And then we have the third option, which is immediate loading. And immediate loading is different than immediate restoration, because an immediate restoration is out of occlusion and no loading. Immediate loading, we typically only do for full arches. That means that we have a balanced occlusion, that we have control of when splinted implants, full arches, and then we can do it. And immediate loading has different definitions. Back in the consensus that was done in Barcelona, it was 24 hours. The most recent consensus states that it's within 1 week. And the reason why 1 week came in is that it's production time. It's technical reasons why we need that time. Something from the dental lab might be produced that we cannot do the same day. So it's within a week, but when we do immediate loading, we do it within 24 hours because it's time without teeth that affects the patients in this. And I think it's the same in your part of the world. So what we're trying to do, and my message and my everything that I'm trying to get you to think about today is that if we are doing patient-driven implant therapy, we need to focus on shorter treatment time and shorter time to tooth and fewer interventions on surgery. Even though we like to do surgery, we should do the surgery that is necessary, not more. But we always have to evaluate the case selection. So it goes without saying that the benefits needs to exceed the risk. Scientifically, go and again, look upon the different protocols of placing an implant and loading, And let's see how they were evaluated on the latest ITI consensus headed by Gallucci, that group. They looked upon the combination of the different placement protocols and the different loading protocols. What they found was, for conventional loading, like conventional loading, what we call late loading, they were documented for immediate placements, early placements, and late placements. They were scientifically documented and clinically validated. We look upon the late placements. We saw that early loading, like when we use rough surfaces, hydrophilic surfaces, we know that they integrate faster in bone. So we're able to do early loading on these, and that is also scientifically validated and clinically validated. If we look upon immediate restoration or immediate loading, when we do a late placement, it's clinically documented. So it's accepted on a scientific level, but it's not as documented as when we did the conventional loading. Same thing if we look immediate placement with immediate loading or with early loading. It's clinically documented and accepted. The only thing that we're missing on documentation is on early placement with early or immediate loading. So that's the only thing that we're missing at the moment for the documentation of doing more immediate treatment. I think I'm going to be saying this probably 10 times tonight or this morning for some of you. It's always interesting to know, why are we talking about this immediacy thing? Why is it so important? What does it matter? Well, to me, it's the patient perspective. If it was my family or it was myself, whoever I knew, I would do the treatment that I felt was best for them. And definitely, whenever we can do a treatment that is a little bit faster, a little bit less invasive for the patient, they will be appreciative to that. So what do we need then to do all these refined solutions? If you want to put this in your toolbox, can you do this with all implant types? Can you do this with all systems? In my opinion, no. You need specific implant systems or specific solution systems to take care of the needed requirements when we're performing these immediate treatments. So let's look at immediate implantation. It's very important that we, in my experience and how I look at it, that we do have an implant design that allows you to do an adaptive drill protocol. That means that we sometimes can make a smaller osteotomy to make sure that we have primary stability on the implant. In the market today, there's a lot of these systems, but I work with what we call fully tapered implants. So the most characteristic things that you will look upon with these implants is a narrow body of the implant and wide threads. We're able then to play with the osteotomy diameter to make sure that we can guarantee the primary stability when we're doing the surgery. I need instruments, and this might seem like stupid because every system should have all the instruments, but trust me, they're not like that fully equipped, all of them. So we need to know that we have all the specific small surgical instruments when we are performing these immediate treatments, and that differs. Well, it also needs to be a direct connection with the implant. There's a pickup system. Some implants have a carrier in between, what we call the implant driver and the implant. That cannot be done when we work with immediate treatments. We need that carrier to be away because we're going to use a little bit more forces. We're going to be actively inserting these implants. And as we are actively inserting these, we are also doing a little bit out of the angle of these implants. We need a tough and strong material of the implant, and that differs. You have commercially pure titanium, you have modified materials, like the mix that Straumann is using with the titanium and zirconia called rock solid. That adds a lot of strength to the implant. So at least the strongest material that you have possible. And you also need it to be a hydrophilic implant that offers you a predictable and rapid secondary integration of the implant. Because the primary integration, the primary stability is just a mechanical stability, while the secondary stability and the integration is an incorporation of this implant into the bony surface. On restoration, if you're going to do immediate restoration, you need a lot of components. They need to be flexible, and they need to be coming in different heights and widths and everything. Otherwise, it's just going to be annoying to work chairside. It's also, again, working chairside, you need the specific instruments to work with. So I would recommend you really to look into the different implant systems before you choose on how to do this. All these systems need to offer a predictable way of working digital. And I would advise you to always, at least in the aesthetic zone, I always use on 100 of 100 surgeries, I use biomaterials to make a predictable soft tissue architecture and soft tissue stability down the road. So we're using biomaterials to maintain the soft tissue architecture. And probably the most challenging thing when you're doing these immediate restorations is taking time. You need to put up time. You do your surgery, good, it's fairly quick. Prosthetically, it does take time. So it's logistics and planning of your schedule. And that's where most of the people are missing this concept in the beginning. When they start doing it, they're running out of time. If you ever start doing this, put up time to do the prosthetics. So let's sum that up a little bit, just saying that, okay, we have a case, we're going to make a treatment plan. So we do an examination of the patient. Together with the patient, this is important, we define the goal. It might be like in this case, there's a wax up, we're increasing the vertical height of the teeth, we're adjusting the smile line, but do the evaluation in the beginning. And then go in depth, of course, and get all the information on the different aspects on the patients. And based on that, you choose whether it's a straightforward case, it's a complex or advanced case. And all these different ways of treating a patient has different aspects and different degrees of difficulty. And by that, the clinical protocols will always be different when you have analyzed the case. So it's important that you take your time. And being a clinician is a combination of knowledge and clinical skills. I've met so many talented dentists around the world. I've also met a lot of smart dentists that has a ton of knowledge, but no clinical experience. And I've also met surgeons that can handle soft tissue like nobody else, but they have no knowledge. So you're going to be your best, and you're going to, be the greatest star on our planet in dentistry. You need to combine clinical skills and knowledge when you are performing treatment on immediate treatment protocols. So it's not enough just reading. You need to do this in the clinic, and it's not enough just to do it in the clinic. You need to be reading. So let's look at this case. Young male. Also being referred as his dentist has placed him a removable prosthesis, elegantly designed with a metal part on top of his front tooth. But by that, you can say that the patient does not have very high aesthetic expectations. So what to consider on this specific case? Well, it's always about, if we're going to do any immediate treatments, we always need to consider the teeth position. And then we need to consider the gingival margin, the height of the gingival margin. I'll show you more pictures of this as we move on. We need to look upon the buccal bone. Is there any defects around that root that needs to be extracted? And then we have something called sagittal root positioning classification. I will also go into detail on that one. We need to evaluate if we're able to do primary stability as we move now in an extraction socket. And we need to look upon if we do have a closal control. So let me show you the picture of this young man. You will see a non-restorable root of his left central incisor. You'll see a medium smile line, which is elegantly enough more easy for us to treat, as the lip will be hiding the part of the buccal gingival margin of an implant crown anyway. And then you'll see the intraoral pictures showing a thick keratinized tissue around the area, which is good. That's what we call a thick biotype. But still, there's quite triangular teeth, so the papilla stuff is quite high. So we need to do our best to maintain these papillas. When we do X-rays, you'll see the intraoral X-ray, and then you also see one of the slices of the cone beam CT. And the interesting thing is to look at the cone beam CT, because that's what we need of all these cases. We need to be sure that we know the way that this root is positioned within the crest. We need to know. So it's very important. So let's see at the classical treatment protocol. Let's do this case like a normal case. So we're doing the examination, we're putting up for an extraction, we're doing a control of the extraction, then we're placing an implant, then we're doing a control of the implant, and then we're doing an abutment surgery, then we're doing a scan and a temporary crown and a control of that one, and then a final crown scan, and then a final crown, and then a control. And you see the minutes. And all of those minutes, that patient needs to be in our office and out of his work or his social life. At this way of treating, he also needs to have local anesthetics 3 times, and it needs to take time. We need to wait for bone healing, we need to wait for integration, and everything goes wrong. So how about that we're at least trying to aim on the potential of at least installing an implant at the time of extraction. So we limit the amount of visits, we limit the time in our chair, which is good for the patient and definitely good for us too. And we're going to have a more happy patient in the end. So by doing this, we are saving the patient from visits, for surgical interventions, for discomfort, and we're providing a much more efficient treatment. If we look at the X-ray of the treatment, you will see this implant being installed at the time of surgery is this is a Straumann bone level implant that was used that time, and it offers a predictable solution. It's a fair aesthetic result for him. He's not very concerned about his aesthetics, but it's good enough, as you will see here. And then you'll see his classical smile line. He's not very concerned about his aesthetics at all, but he's, you know, happily smiling young Norwegian male. So this is how he's going to be looking. And we've saved him a lot of dental visits by at least installing an implant in the extraction socket. So if you look at this soft tissue thing that I wanted you to have in your mind when you're considering if you're going to do immediate restorations on top of an immediate placed implant, you'll see on these cases what I call the positive symmetry of the soft tissue. So the soft tissue of the tooth that needs to be replaced needs to be on a better level. That means inferior to the neighboring teeth. Because if you do have a gingival retraction before you do your surgery, it's not going to be better off when you're putting a temporary restoration on. So that's one of the limiting factors of doing immediate restorations. I'll show you the negative ones. They will either be looking like this with infection, which is not a way to, this is not where we want to do anything like immediate, or they're going to have what I call a negative profile, meaning the gingival margin of the teeth being needs to be replaced. They're superior to their neighboring teeth. So all of this, what we're doing now is trying to add something of our own into the play of the treatment planning. And the way that we're adding something is by acquiring knowledge and clinical skills to avoid cases like this. Because this is what it was done like 20 years ago when they were working in extraction sockets. And by doing a good clinical work, which they did that time because they managed to do it, but with limited knowledge on biology, this is the result that we get down the road. And as you probably have been taught about in other seminars, doing soft tissue grafting on implants is much more difficult than doing it on teeth after the implant are installed. So these two young girls with a high smile line and this, that's not how we act. So it's not throwing away, getting everything in because you can do it. It's getting the knowledge on understanding the biology and knowing what we need to consider when we place an implant in an extraction socket in the aesthetic zone. And I'll try to take you through a couple of these decision-making things that you need to make sure that you have control of before you decide the case. So let me give you some checklists. And if we are after this down the road, any one of you needs any of these slides, whatever you need, or lists or whatever, you will contact me and you will have everything. There's no secrets in here, so feel free. So by implantation, we need to have infection control. That means that we are avoiding active infections sites. We're not placing implants in those. But with chronic infections, chronic apical infections, it's good, documented, that it does not affect the survival rate of implants as long as we carefully clean the area before we are inserting the implant. The position of the root, as I've mentioned before, I'll come back to that one. Buccal bone defects, really important when we're doing this. And also the consideration of bone apical or palatal to the alveolus. That has a high degree of value when we're deciding on immediacy or not. And of course, by that, there's also the relationship to the adjacent anatomical structure. It could be the nerve in the lower jaw, it could be the sinus or the nasal furrow in the upper jaw. On the immediate loading or immediate restoration or temporization, it's tooth position or tooth position. I mean, if it's a posterior molar, I don't know, the value for the patient of having a tooth in there at the day of surgery might not be that big, but if it's central incisor, smiling area, aesthetic area, it has a function, it has a meaning. Gingival margin, positive, negative, important. Buccal bone again, coming back to that one. Root position, and the same thing. Ability to obtain primary stability, which we can do when we work with fully tapered implants and has the clinical skills to apply it. Occlusal control, logistics, and patient issue. What do I mean by patient issue? If we are inserting a temporary crown on a patient, we are instructing the patient not to chew on it because it's not supposed to be loaded. So if it's a central incisor, use your fork and knife and chew with your posterior teeth. Don't bite with it. And if the patient doesn't understand how complex and refined and nice these solutions are, they should not be taken into the immediate world. They should be kept on classical work. So the two most limiting things is logistics and patient issues. And as we move down this pathway, you will learn that it's the case selection again, that it gives you success or grinds you the failures if you're not doing it. Let me just give you a hint on a bone defect classification that I would like you just to have in, get it in your spine, back of your head so that you know this one. It's again by the group of Joseph Kahn. It's showing that if you have what we call a V defect, a small defect that is just like on the mid-facial portion of a tooth that needs to be extracted, that's okay, it's green. We're okay by that. If it's U-shaped, it challenges because it will go out to either the mesial or distal part, meaning that we have a lower attachment level of the tooth. And when we have a lower height of the bone, we very often see a gingival recession combined with inserting the implant just at the time of surgery. And if we have what we call an ultra U-shaped, that means that we have the defect going out on the neighboring tooth. We don't have support for the soft tissue. And that has a high degree of, I think we have the percentages. I mean, this is just like how many of the cases treated with these defects are showing a gingival recession of minimum 1 millimeter or more post-operative or after that we had the tooth in function. And it shows by the ultra U-shaped, it's 100%. So don't do any immediate treatments on ultra U-shaped. On U-shaped is like flip a coin. It's nearly 50%. You want to do that? No. V-shaped, yes. Like below 10%, well, that could happen if you did it classically anyway. So with this one. So those are defects like that you will see when you evaluate the case. But if you're not able to extract the tooth atraumatically, you're providing these defects anyway. So just look at these beautiful, nice teeth that took away most of the bone for this patient to place the implant in. So we need to train, we need to have the clinical skills of doing a very careful extraction when we work in the aesthetics. I will also then go into the sagittal root position classification, because this one will help you do the decision on when to work with immediate protocols. and also how to apply the knowledge of this into the surgical procedure. So class 1, which is the most common one, means that we have the root towards the buccal plate. That leaves a lot of, let me see if I can use this one, yes. It leaves a lot of space in the palatal bone to place the implant, and that is extremely important. The class 2 has a centered part of the root. That means that there's another drill protocol when we work with a class 2. A class 3 is positioned towards the palatal bone, which could be a little bit challenging. And class 4 basically doesn't have any bone on neither the outside or inside, so that is a dead end trap if you ever try to go for any immediate treatments on these cases. So these are exemplifying these different cone beam slices that show you that this information is needed. I'll show you a little bit also about the spread between class 1, 2, 3, and 4 as we move down the rest of the lecture. Why is it important? Why do we need to know all this? Because, as they say in in England or UK, they say mind the gap. That's when you leave the tram. There's always mind the gap over there. Mind the gap in this thing is how we act and how we apply our biological knowledge to the gap between the implant and the buccal wall. So let's just try to make a little bit on this drawing. Let's say that we have what you see now on your left, you see coagulum. You will see the remnants of the PDL. This is just like straight after the tooth is extracted. And then we have what we call the bundle bone. This is by the group of Jan Linde in Gothenburg and the Brazilian Araujo that did a lot of this work. And they call it the bundle bone. So the bundle bone is what they define as being a part, basically being a part of the tooth, because the blood supply comes from the PDL. And when we extract the tooth, PDL disappears, blood supply disappears, some of the bone needs to disappear as it will have no blood supply. So I'll just color that bundle bone and I'll show it around on the extraction socket as this. What you will see is that in the buccal surface of this bone, basically all of it will be bundle bone. And that's why we see what we see every day when we extract the tooth in this area. We see a natural remodeling. So the buccal bone will be lowered due to the fact that some of this height is consistent with only buccal. And in the projects that the group of Araujo and Jan Linde did, they showed up to 2.2 as an average of lowering of height of the buccal bone after extraction of the tooth. So what did they do before? Well, they had these extraction sockets and the knowledge on primary stability was established, but biology was not established. So what they did was they found the widest implant and then they anchored these implants into the extraction socket by integrating it with, getting in contact with all the walls of the socket. And that Nobel Biker did that with this type of replace implant, and then Straumann came up with something they called the Straumann T implant that was also meant for extraction, so really like pushing on the top of the part of the extraction to gain the primary stability. What we know is that the bone disappears anyway, and by adding pressure, more of it disappears. So as we moved along, and I think it was in 2005 or 7, I think 5 it was, 15 years ago, Araujo published one of the groundbreaking understanding of the healing patterns of an extraction socket. So that led us to placing an implant in the palatal bone, leaving a gap. Because in that gap, we could still use biomaterials to make a framework for rebuilding bone, so we don't have the lowering of the buccal bone accompanied by the lowering of the soft tissue. So this is the mind the gap thing, which is something of the most important thing that you need to know. So we're not placing implants in extraction sockets. This is the sentence you will hear often, that people are placing implants in extraction sockets. We're not. We're trying to find bone outside or inside of the extraction socket. So if it's in the aesthetic area, we're trying to use the native palatal bone to place the implant. If it's a posterior one, we're trying to use the intraradicular bone. The septum or the septa of after the tooth is extracted is the place that we're placing implants. So we're not trying to anchor in the extraction socket. We're trying to find the native bone, either apical or centrally or palatal, to this extraction socket. So if we do a case like this, we're extracting a tooth. Just look at the angulation of the drill. I don't know how many implants you've placed or if you did that already, but this is, you know, normally you will be placing like this, but this is basically like this, because we are going into the palatal bone before we are changing our direction. So just look at this is what I would say is the direction of the alveolus, and this is the direction of the drill. Because if you now remember the classification of the sagittal root positioning, this is a class 1. We need to get into the palatal bone, and then we're, you know, angulating up, like I'll show you here. So we're changing direction of the drill, but we need to get into that palatal bone to make sure that we're getting it. That's why if you did this on a class 4, your drill would be in the palate. If you did it on a class 3, your drill would be in the palate. So you need to know if it's a class 1, 2, 3, or 4. That's why we need this information. And you see the osteotomy, you see the extraction socket, the osteotomy, and the finalized osteotomy, you will see it at the palatal surface of the extraction socket. So we're not placing implants in extraction socket. We're placing it in native bone. That's how we try to solve these cases. So, do you want to go for a new start when we're doing implant surgery? You want to have, I don't know. I finished dentistry 21 years ago, a dentist school. And I was always told that we worked classically, save, wait for healing, extract, everything. My statement today, which I tell all the dentists that work with me or in our clinics, I say that, hey, never remove a tooth without at least consider placing an implant. Doesn't mean that you're going to place implants in all extraction socket, but before you remove the tooth, please make up your mind if this is something that we could save the patient for time and surgery by placing the implant at the same time. So I'm going to take you through a decision tree that will sum up a little bit of this information, and then we'll go through a nice case of one of my colleagues that I've treated, and then we will see if we are getting through a decision that might help you with some information. So let's go on buccal bone. Is it intact or is it defect? That is a thing to get into the first part of the information that you are collecting when you are evaluating a case in the aesthetic zone, and you're going to decide if you're going to do an immediate treatment or not. If it has a defect, how is it? Is it a U or an ultra U shape? You remember now, it's 50 to 100% success. Sorry, not success, guarantee that you will have a gingival recession. So if it is, no, get it out. Not case. Go classical, extract, go. You might go for early placement, but at least do not go for immediate placement. If it's a V-shaped or it's intact, hey, good. Then go for the classification of the sagittal root positioning. Is it a 1 or 2 or 3 or 4? If it's a 4, get rid of it. You can't do it on immediate procedures. If it's a 1, 2, or 3, and it has apical bone, then we're good to go. Then we can work, but we need to know, because we need to know how to angulate that drill before. So we need to know if it's a 1, 2, or 3. So there's apical bone, no, get rid of it. If there's no apical bone, not a thing for immediate procedures. If it's a yes, look at the gingival level. And remember now the positive and the negative part of this one, if it's a higher or lower gingival margin of this. If it's a positive, it's not only a candidate for immediate placement, also a candidate for immediate restoration. If it's a negative one, it might still be a candidate to place the implant, but it's not a candidate for restoration. So this young female is my hygienist, one of the hygienists that works in the clinic that I'm working in Stavanger. And this is Monday morning, about a year ago. And she comes in like this Monday morning, a little bit before she starts, smiling but not smiling. And you'll see why, because one of her central incisors is fractured. You see the resorption of the root after probably an orthodontics in her childhood. She's about my age, and the tooth is root canaled. It's been bonded with prosthetic 6 years ago. And I said, hey, we can rebond, or we can make a new crown that you can use for this one. And she says, well, I haven't been chewing on that tooth for 6 years because I don't trust it. So I would like you to do an implant. And I said, okay, you're my colleague, you have a high smile line, there's different things, so we need to do the whole analysis and the whole evaluation. So let's see if you remember some of these analysis steps that needs to be done when we do this treatment. We need to look at tooth position, which is given by this one, so it's of importance to the patient. Gingival margin, buccal bone, the position of the root, the potential of obtaining primary stability, and if we do have occlusal control, so that we know if we're going to place an immediate restoration tooth, we need to know that the patient is not does not have any potential of disrupting the integration process by not controlling the occlusion. So let's look at these factors. Let's look at this. I think we can look at the soft tissue first. Yeah, soft tissue is good. You see now, we do have what we call a positive soft tissue profile. Means that we do have a little bit of soft tissue to work upon. It's good. And then we look at the buccal bone. And this one, we see that there's intact buccal bone. There's no defects. So that's good. Scroll through your cone beam CT, you see. And if you remember now, you know that this is a class 1 positioning in the sagittal slice of the cone beam CT. And you see that class 1 offers you about 80% of the cases, while the rest of them, like 2 and 3 is very rare. It's like around 1%. So you're not going to face it often. But class 4 is more than 10%. And if you don't know you have a class 4 and you start your procedure, you will have a big challenge. That is very often where you, down the road, your first 2 cases is beautiful, successful, and then you meet the class 4 and you didn't do this analysis, and you don't know, and you drill out, and you lose all your confidence, and then you start not doing immediate treatments. So get away from that one. And then the bony defects, as you saw, we know that there's no defects, so we call it an intact class 0 something, and it's important because this provides stability for the soft tissue aesthetics afterwards. And then we look upon the occlusion. We see that, well, you know, she's not in like perfect alignment with all the teeth, but there's good occlusion. There's control of that one. She has all these sliding parts of the canines. That's good, so we can control whatever hits a temporary restoration if needed. So we check out all of these. It's green, 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 green. So we have control of that one. That's the analysis of this. So that was the first analysis we did. We did it the same Monday, of course, with my colleague. Then we also add another analysis that I would recommend you to use in the clinic, which is the aesthetic risk assessment published by the ITI years ago. And it goes through like medical status, smoking habits, aesthetic expectations, smile line, biotype, shape of tooth crowns, infections, bone level, restoratives, if it's 1 or 2 or 3 different missing teeth, soft tissue anatomy, and bone anatomy. This analysis, you might be able to, you know, by clinical experience, to do it in your own head. But the important is to use this analysis and even show the patient that analysis, because if there's a lot of red things, like high risk of aesthetic complications, it's much better to inform the patient in front of the treatment than trying to explain it afterwards. So we use this as a part of the patient communication always. As you see here, the only thing that is actually on aesthetic risk factors is the high smile line. She's even on median on aesthetic expectations because she knows. So by all these analyses, which you systematically do on all these cases, not just one, you do it on all the cases you have every day, you do this. You get to do choices. And my choice is always immediate whenever the benefits exceeds the risks. So on my colleague now, it's Monday morning, we've checked out everything, said, hey, you're a candidate for this, and I think the best treatment I can provide you with is go for an immediate procedure. And I'll take you through this immediate procedure to try to show you as a part of the treatment concept how we do this. So we would classically, this again, do the cone beam CT and the intraoral scan the same day. The intraoral scan and the cone beam CT could be merged, and we can do the planning in the software. That's one thing. The other thing is that we need this scan, or if you do a conventional impression, for the lab to make what we call a prefabricated outline of a temporary crown. So I'll show you how we do this by using the intraoral scan, by providing ourselves with digital files and easily send them to the lab, which in this context, we do have a lab within our DSO, which is situated in the capital, which is an hour flight. So it's just, and in Norway, 1 hour flight takes about 8 hours to drive because we have small and bulky roads. So it's not it's not in and out of the door. It needs to be transported. So that's why we work with digital files. And that will come into this one. So we have a digital file, and we have the dental technician then design what we call a temp shell. This is what you see in the gold colored stuff. You see it has wings, so it's resting on the neighboring teeth to make sure that we have the positioning of this when we come into the clinic. Let's look about if you can stream, if we're able to stream, depends on your internet capacity now, but it's streaming the video. You see that I'm just carefully extracting the tooth without doing any flap, but just releasing the fibers. That's an easy tooth to remove. And then we're doing what we call the pilot drill. The needle drill goes into the palatal bone, so it goes with the angulation before we go up. And then we're gradually increasing the diameter of the drills. This is 2.2. This is the Straumann BLX system, but you can see the colors of the Straumann. So yellow is 2.8. And we are finalizing this case with a 3.2 millimeter osteotomy. As a white. And you see now the implant being inserted with a manual screwdriver, basically, what we call a surgical screwdriver, because then we're able to insert and really hit that part of the osteotomy that we have on the palatal. And we can just anti-clockwise rotate a little bit to reduce the torque when we need to get further in. And now you see the buccal space between the implant and the buccal bone, the gap. And in this gap, we are using what I call a non-resolvable biomaterial, or a slowly resolvable, as somebody says, slow substitute rate on xenograft. So it's xenograft bone as this. And then we do have a collagen sponge, as you see here, that I'm just placing on top of the biomaterial to contain it within the gap, and also make sure that the prosthodontist that will come into work now is not destroying my bone and taking all of that weight, because we are working in teams where some of us are doing a lot of the surgery, and then we have prosthodontist or restorative dentist that are doing that. So this is how it looks when it leaves the operatory room. And then the tooth temp shell comes into life as this. So this is how it looks. This is just a hollow shape of a tooth that is specifically designed to this patient. And then we're just, the prosthodontist or the restorative dentist is just adding, as you see on the x-ray, you'll see a temporary abutment on your left x-ray. You'll see the temporary abutment being adjusted in height. And on the right side, the right x-ray, you'll see the finalized temp abutment with a temp crown on. And it's going to look like this in the clinic. You'll see the wings of this one coming out on the sides. And we're using that to maintain the correct positioning of the tooth after it's done. As you see on the third picture, towards the right, you'll see the finalized temporary crown being screw retained, which is very important because there's no cement in this, so we can take it on and off whenever we need to. And you see also from the profile that this is good. So this is same day, and it's about 60 minutes after we extracted the tooth. And this is my colleague smiling after the anesthetics, of course, is trying to get out of this lip. But she's back at work the same day. And she's my colleague, she's my employee. I don't want to keep her out of work too much. And then you'll see the follow-up of this. This was before summer last year, so day 0. That was week 6, that was after summer, and then at finalization at week 12. I think she's happy. It's a good aesthetic result. And what I like, because I'm a pink dentist, so I like soft tissue. And I like soft tissue architecture, I like soft tissue quality, I like the shape of it, it's beautiful. I did marry a psychologist, so, you know, to get me diagnosed if I'm putting pictures of soft tissue on my wall, but I like soft tissue, so I like the pink one. And looking at it again from a patient perspective, what did we obtain for this young lady, which has all the knowledge around implant therapy, as she's a hygienist that works with follow-up of these patients? Well, we gave her fewer visits. We gave her fewer surgical interventions, less discomfort. There was a fixed tooth all the time, and overall a more efficient treatment. What did it provide me? Well, we took her less time away from work. And being an employee here at these days that we had the COVID-19 situation very heavily hitting Europe, we want to keep people at work. So let me finish off with just an interesting case. I just want to show you this because it's the thing that I put on my mind every time I feel, you know, sorry or sad or something, and I might be doing mistakes in the clinic or something. I put on this case because I think we did something very good in this case. So this lady walks into the office like this. You see that there's a lot of caries in the upper jaw, and we don't have any solutions. She's with one of my colleagues, so they're trying to get all these loose bridges before she swallows or inhales them or everything, so cleaning up. And she comes back to this. She's now wearing a removable prosthesis, but she's basically not able to use it. There's no retention. She has limited ability to do all these things. And then we decide that, okay, we're at least gonna do an immediate loading of the implants that we put in. So what we're doing is that we're doing a surgical procedure. I'm placing 4 implants. I'm getting the primary stability of only 3 of them. The 4th implant is not stable enough for me to load it at the day of surgery. So it's not a good feeling at the moment, but we're doing the temporary bridge. So she get rid of the removable prosthesis. So she's happy, much better, everything's good. And this is then restored 3 months after with a final restoration, which is this. So why do I feel so good about this one? Well, we treated her in 2018. And at that time, she was 101 years old. So the fun thing about this is that, you know, we basically didn't have time to do conventional loading. You could potentially lose the patient in between here. But we did this for a 101-year-old lady. Her daughter is a medical doctor, which said that you should do the best treatment that you could do for my mother, because the discomfort of having the removable prosthesis is taking away so much of life quality. So this case brings me smiling and everything. This is the 2-year control. She's now 103 years old, and she's still smiling. She's still coming for follow-ups. I like the bone level around these implants. The jaw was this thin and the bone quality was lousy, everything, but we still managed to do it because we work with these specific protocols and implant systems. And it's not very like aesthetic and beautiful as a prosthesis with her, but she's extremely happy. And she's chewing and she's smiling. So that brings motivation for still trying to do more patient-oriented treatments. So if you start with anything new, if you start by going immediate or immediacy treatments, you will find yourself in a learning curve. And most of us, we should wish that our learning curve goes like this and it goes up. So that's good, because, you know, we would like to be that way. Sometimes there's the Dunning-Kruger effect. You've probably heard about this one before, but it's very interesting because you will see it in your social life amongst your friends or relatives or anything. And hopefully we are not a huge part of this, but it's interesting anyway. I'll show it. So it's from the phase of know nothing to the phase of I got it to the phase of valley of despair to the guru part where you know in the end. So in the know nothing phase, you don't know what you don't know. It's good. It's a happy life. I mean, it's like being a kid. We don't know what we don't know, so we're happy. In the I got it phase is where you think you know, but you still don't know what you don't know. In the valley of despair is where you realize that you now know what you don't know. And that's when complications occur. That's why you learn that, oh, we couldn't do all this on all patients because it didn't work like that. Ah, we needed that. So, and then we gradually again build up. And in the end, just before we leave this part of the world, we might be on the phase of guru, which you know, well, you know. The danger part to be, or the danger place to be, and don't hang out there too much, is on this one. And this is what we call the Mount Stupid. So realize that whatever you do, whatever you hit on knowledge, whatever you're trying to develop, you will probably have disappointments, you will probably have complications, you will probably need to strive and get, you know, what we call on the sweaty side of it, meaning that you have to do these challenges. You have to get through this, but work with experienced people. Learn yourself the knowledge around it. Train your clinical skills. And you will probably get past that Mount Stupid much more often than you're on top of it. So by that, I wish you all the best of luck. And I truly hope to get to visit you in Mexico sometime or in the whole part of South America, as it would be fun to visit that one. And if anyone would like to contact me on social media, you'll find me on Instagram or Facebook. Please feel free to reach out. And if there's anything you need, I mean, I can send whatever you need to wherever you need it. So Carlos, I'll hand the word back to you. And if there's any Q&A, feel free to hit it.
Thank you so much, Eirk. Your presentation is very good looking presentation and with so concrete concepts. Where's your opinion? That's a question. Where's your opinion about soft tissue grafting in immediate implants?
I think it has a fair value in some of the cases where you have a very soft or thin biotype. Then soft tissue grafting, or what we connective tissue. This is what we do. So we do connective tissues on these thin biotypes. But I think it's also adding complexity, and it adds even more need for clinical skills if you do this. But most of these cases do have the anesthesia on the palatal surface, so it's easy to grab a connective tissue graft if you would like to apply it. We don't use it on all cases, but we use it on the thin biotypes.
Another question, otra pregunta. In the full arch clinical case that you showed, how often do you program the maintenance for this patient? Because we know that this kind of patients maybe could have difficulty with oral hygiene, like a power toothbrush and something like that. What is your program for this kind of patients in maintenance?
On an overall level, it's like all implant patients that we treat are recalled every 3rd month. So every 3 months they are recalled until the opposite is proven. That means if you have a young lady or something with excellent hygiene, it's a trauma case, and she's in 3 months, we know that the risk profile is very low. But we keep her on 3 months until the first visit is done. Okay, we say, hey, this is good enough. We keep you on like 1 year. But we keep them very tight in the beginning before we release this part going more forward. So if it's a perio patient, they're obligated to go every 3 months. This lady of about 103 years old now, she is not recalled every 3 months because the picture you saw is without cleaning from us. So the picture you saw, the clinical picture, excellent hygiene of 103 years old with power toothbrush. Yes, every 3 months.
Every 3 months. What's your opinion about electronic devices like water pick for this kind of patients? Other questions.
What? Come again. What was the question, Carlos?
What electronic devices like water pick, like oral range irrigators?
No, it's not removing biofilm.
Okay.
No, it's flushing food.
So you recommend like a flossing, super flossing?
I use brushes.
Brushes, okay, interproximal brushes. So, well, thank you so much, Eirk. For me, it's like a pleasure being here with a friend or like a brother. So, where you have a home in Mexico, where we place it with in the future, you'll be coming here. So, thank you so much, and all a big hug with the distance for a Norway colleague. So, thank you so much for Oris, and well, it's an honor for me to be here with you.
Thank you, Carlos. I wish you all the best and stay safe. And I'm looking forward to seeing you. Thank you.
Well, gracias amigos de Perio MX Academy. Acabamos de terminar la sesión 29. Mañana nos vemos con la sesión 30, la última sesión de Perio MX Academy. Bye.
Bye-bye.